All right, catheter thrombosis. Oh boy! Here are my personal steps of escalation for clotted CVC. First, I change the needleless connector because that's the most easiest, cheapest way to fix this issue and pretty common. And then it's a 2-view chest x-ray. Do you know why I want 2-view and not AP? Because a catheter can get displaced in the azygous vein. And it's sometimes, depending on the anatomy, difficult to tell if that azygous vein is in the cavoatrial or not. It's kind of overshadowed a little bit. So you want to make sure. I've seen x-rays where we did the 2-view and we saw that it was like dipped in. I was like, oh, that makes sense. That's why. Okay. Now, displacement of the catheter tip, catheter folding and kinking, pull pop technique. This is controversial, but I have studies to back it up. At the end of the presentation, all my references of everything I'm talking about is in there. They did a study in 2020, I believe, that recently published to show the efficacy of this. Gentle 50 to 200 ml pulsatile flush if there's partial occlusion and if they do not have contraindications. If they're fluid restricted, don't do that. You're gonna have to use thrombolytics, all right? Now, thrombolytics is the second to last, and then if we can't do it with thrombolytics, we have to replace it. Why would thrombolytics not work, do you think? How? Yes. So, I can tell by an x-ray if you pushed or if someone pushed that catheter back in when they weren't supposed to. You know why? Because in the subcutaneous tissue, it'll kink. It'll bend and accordion squish into itself. Yeah, so that's why during the x-ray you want to get that exit site as well. Okay? So these are the reasons why, or these are the escalation steps that I personally take. This is not a standard recommendation. This is just what I found to be the least this is most cost effective, less invasive.